End-stage renal failure. End-stage renal failure is the point at which an individual's renal function is no longer sufficient for normal life as a result of irreversible loss of renal function, i.e. the point at which renal replacement therapy should be commenced, if appropriate for the patient. Etiology, pathophysiology, and pathology. At a certain level of glomerular filtration rate, GFR, the accumulation of molecules that are usually excreted by the kidney reaches a level at which they prevent or endanger normal physiological functions. The principal problems are potassium, salt and water, hydrogen ions, uremic toxins. The term uremic toxins refers to the vast numbers of chemicals that accumulate in the blood as the kidneys fail. Urea and creatinine are the two measured in clinical practice, but they do not correlate very strongly with uremic symptoms, those made better by dialysis. Elderly people and those with less muscle mass will have a lower GFR for any given creatinine than is normal, and will reach end-stage renal failure with a lower creatinine, e.g. 450 moles/L as opposed to 850 moles/L. NB. As patients approach end-stage renal failure, they frequently become malnourished because of loss of appetite, resulting in muscle wasting and deceptively low creatinine. The correct treatment is dialysis and attention to nutrition. Epidemiology. The take-on rate for renal replacement therapy in the UK is approximately 100 per million population per year. End-stage renal failure is much more common in elderly than in young people. Causes are the same as for chronic renal failure, CRF. Clinical presentation. Symptoms are sensitive, but not very specific. Tiredness and difficulty concentrating. Loss of appetite. Nausea and vomiting. If these symptoms are present in a patient with creatinine greater than 450 moles/L, serious consideration should be given to commencing dialysis unless there is another cause, e.g. anemia contributing to tiredness. In severe cases, presentation may be with pericarditis, uremic encephalopathy, or neuropathy. In other instances, the need for dialysis will be precipitated by acidosis, hyperkalemia or fluid overload resistant to diuretics and sodium restriction. NB. Monitoring patients with renal impairment as they approach end-stage renal failure should enable them to be commenced on dialysis at a time when symptoms are minimal but they will feel a clear benefit. Early referral to a renal unit enables emphasis to be placed on delaying the progression of end-stage renal failure, avoiding complications, and making the appropriate physical and psychological preparations for renal replacement therapy. Physical signs. Commonly, there are no physical signs when a patient reaches end-stage renal failure. Less commonly, pericardial rub or metabolic flap may be present. Peripheral neuropathy, uremic frost, and fits are rare. Investigations. Identify the cause of the renal damage if possible, as for CRF. Establish that the diagnosis is CRF. Look for small kidneys on ultrasonography and evidence of previous renal impairment. If kidneys are normal size and not obstructed, a renal biopsy will usually be indicated. Consider whether there is a reversible factor causing acute on chronic renal failure, volume depletion or hypotension, nephrotoxic drugs, e.g. NSAIDs, or prostatic obstruction. Test for hepatitis B and C. Potentially infectious patients will require special dialysis arrangements. Others should be immunized against hepatitis B. Treatment. Commence renal replacement therapy. If the need is urgent, hemodialysis will usually be used initially. If there is cardiovascular instability, hemofiltration may be preferred to begin with. Emergency treatment for hyperkalemia may be indicated pending transfer for dialysis. NB. It is unwise to defer dialysis. If in doubt, dialyze first and ask questions later. It is important to appreciate that dialysis is equivalent to only a low level of GFR, in the region of 6 ml/min. Although sometimes patients, and occasionally their doctors, will suggest dialysis in the context of less severe renal impairment, this would represent a relatively small increment in clearance compared with the patient's own renal function. This is unlikely to lead to clinical benefit, would be at considerable financial cost, and would also be a major inconvenience to the patient. Complications. The following are particular problems in patients with end-stage renal disease treated by dialysis. Increased cardiovascular mortality. Autonomous hyperparathyroidism, requiring parathyroidectomy. Accumulation of beta-2 microglobulin amyloid with carpal tunnel syndrome and arthropathy, specific complications of the renal replacement therapies. Prognosis. In appropriate patients, dialysis can usually be performed relatively smoothly and safely, especially when adequate practical and psychological preparation is made. On renal replacement therapy, mortality is much higher than in a population matched for age, diabetes, etc. Prevention. Measures to prevent progression of CRF. If there is sufficient advance planning, transplantation, from either a living or cadaveric donor, before end-stage renal failure is reached may avoid the need for dialysis.